Good morning, everybody. So we have three topics for today's conference. So those three topics may require more than one lecture, but we have to conclude all of three lectures within a single day. So first, starting the topic, then we'll start with the polio. So the polio is the most common topic to all of you. You may have gone through poliomyelitis or pediatrics or medicine. So slight difference of what does the polio have in orthopedic manifestations. So we shall start with dealing with all of these things. So polio is caused by a virus affecting the anti-neuron cells. So polio virus affects the anti-neuron cells, causing the lower motor neuron paralysis. So, so it usually affects the anti-neuron cells and sometimes the brainstem as well. So which eventually leads into a form of a paralysis, which is a lower motor neuron paralysis. So what are the clinical features we encountered in orthopedics manifesto in poliomyelitis? So there are a lot of stages. So it's divided as per the stages. So one can have an acute stage, one can have some stage of a recovery, and one can have a stage of residual paralysis. And there is a next step also. It's also called post-polio syndrome, which I didn't include it over here. So it must require at your level. So starting with the acute phase, the acute stage onset. So it's also called the pre-paralytic phase. So there is no paralysis at the beginning, which usually lasts for 7 to 10 days. Usually it's onset. There's a the child is a febrile, or the patient is febrile. He have a history of diarrhea. There is a severe muscle tenderness, and there is overactivity of the muscles. And usually, what the child complains is the intramuscular injections are often painful for the child, and they should be avoided. So during the later phase of acute stage of a poliomyelitis, so what happens is there is a phase of a maximum paralysis. So it follows the pre-paralytic phase. There is an asymmetrical paralysis of a part or a whole of limb. So this point is much of importance. Poliomyelitis never causes symmetrical paralysis. It's usually, most of the time, it causes asymmetrical paralysis of a part or a whole of a limb. So the lower limbs are much more involved than that of the upper limbs. And this is stage of a maximum paralysis. Acute stage involving the maximum paralysis can last up for 2 months. Then there is a stage of recovery, which lasts from around the end of a maximum paralysis from 2 months to 2 years. The recovery is maximum in the first 6 months. The recovery can take place till the end of 2 years. So from the end of a maximum paralysis, which usually ends by 2 months of duration, it can last up to 2 years. So if a child has a maximum progression or maximum recovery within 6 months, he has a very good prognosis. So though he can have a recovery till 2 years of his life, but the maximum recovery happens within the first 6 months of the occurrence. Then the other stage is the stage of residual stage, so which happens after 2 years. So if there is no improvement, if there is no significant improvement within 2 years, the child has very less chance or least likely that the child will have improvement. So there is no further recovery, and the deformities are to be corrected by some surgical form of treatment. So here are the two pictures of a poliomyelitis. In the very first picture, all of the 4 limbs are involved, and in the second picture, the lower limbs are involved. So there are certain deformities that one encounters in a poliomyelitis. So this is a gross picture how a child can have, or how a patient can come to you with some deformities, with some orthopedic deformities. So if you go with the spine, if you come through the spine from the top, the spine can have a scoliosis. The pelvis, there is a pelvic obliquity. And over the hip, there are the flexion, abduction, external rotation deformity over the hip. Coming to the knee can have a flexion and the valgus deformity. Along with that, there is the chances that there is the callosity due to the crawling. The forefoot and the hindfoot deformities are present. There is equinus at the ankle, and the significant point is there is a limb length discrepancy. If a child has, there is a significant limb length discrepancy is present. So, what are the causes of deformity we encounter in orthopedics due to polio? So, there are a lot of theories, a lot of explanation regarding that. So, one can be the faulty posture, the other can be the muscle imbalance, and other can be the skeletal. So basically, three concepts have been postulated for the causes of the deformity in a case of a poliomyelitis. So regarding the faulty posture, it can happen in the acute stage. So the paralysis due to the gravity effects uh, leading into the faulty posture of a child. There is the asymmetrical muscle balance, which eventually leads into the faulty posture. So there is a significant muscle. The other cause or the other concept that explains the cause of a deformity in a case of a poliomyelitis is a muscle imbalance. So during the recovery stage, so it happens usually in muscle imbalance, usually happens in a phase of a recovery stage. So there is an imbalance over the muscles, over the limb. So more and less involved muscle groups. So somewhere the muscles are involved more, some antagonist muscle studios are acting are involved less. So this creates the imbalance between these two group of muscles. So one of the representation case of in the spine, which results in the scoliosis. The other concept for the cause of deformity is ischemic growth. So what happens in ischemic growth is it continues even if a child have a disease, even if a child have a poliomyelitis, the ischemic growth continues normally. So there can be the paralyzed muscle, there can be the atrophy, the muscles can have atrophy, muscles can have a fibrosis. So they do not stretch with the ischemic growth. The bones grow, but the muscles doesn't correspond to the bony growth. So this results into this deformity. So coming to the part of a treatment in a poliomyelitis, if a child presents you in the acute stage, so the correct posturing of a limb is very essential into the functional position. So limbs should be corrected or posted in a functional position, either in a splint days, or some sort of a plastering procedure, or whichever way the patient is comfortable. So associated with this splint days, the active and passive mobilization of the joint is very essential. So the active and passive mobilization of the joints prevents the shortening as well as the atrophy. It prevents the stiffness of the joint, and the symptomatic treatment can be conducted as per advice by the pediatrician. So if the child is into the recovery stage and he comes to you, so all the principles of active staging are applied. That is, sprint days into the functional position, passive and active range of motions are given, and the symptomatic management is given. Aside from that, the accurate neurological assessment and the orthotic fittings are to be provided. That supports the paralyzed limb, that prevents the deformity. So coming to the residual part of a paralysis, so there are a lot of principles occurring involved in that. So the principles can be the correction of deformities, the correction of a muscle imbalance, stabilizing the joint, and orthotic managements. So coming to the first principle, the correction of deformities, it is done in the early stages. The later there will be adaptive bony changes, and the surgeries includes usually the soft tissue release, like the tendon, fascia, capsules are released, and the tendon lengthening as well. And associated with that, we can do the corrective opportunity. Uh, the second principle in the treatment of a poliomyelitis is a corrective muscle imbalance. Uh, so we try to correct the muscle imbalance. So we prevents the formation and recurrence of the deformity. We improve the function of a limb. The surgeries can be conducted. We can conduct the tendon transfer, the weaker muscles in the form of weaker muscles. We supplement with those muscles with the tendon transfer, and so we can correct the muscle imbalance. The third principle is the stabilization of a joint. So we improve the functions of the muscle acting on the distal joint, as it now has to be on the lesser number of the joints. Or we can go through the surgical part with the orthodosis of a joint. We can fix the joint in the functional position, in a much functional position. So the final one is the orthopedic appliances. So if all of these measures, all of these remedies do fail, what we can do is we can give the child orthopedic appliances needed in children if the deformity is likely to be developed or is corrected. So joints with weak muscles and unstable parts to be impaired and should be light. So the principle of orthotic appliance is that so It involves the joints with weak muscles, and those are unstable, and those should be light and as well as the inexpensive. So thank you. So now we'll go into spina bifida. So other form of deformity we encounter in the pediatric size group is spina bifida. So spina bifida is just a failure of a fusion of a vertebral arches, so producing the defect in the posterior midline. So with or without the demand of the spinal cord and the members. So there are two types, like so it's a failure of a fusion of a vertebral arches, producing the defect over the posterior part of a spinal cord, or usually say the lamina. So of lamina of the vertebra, there is a defect. There is a midline defect, or there is a complete absence of a lamina, so causing the neural elements to protrude outside. So that is a form of the spina bifida. So it is of two types: spina bifida occulta and spina bifida aperta, or you can say it is cystica. So of this spina bifida cystica is again divided into two forms: meningocele and myelomeningocele. So this is a case of a spina bifida occulta. So the neural elements are inside, so there is a defect. So this is a portion of a lamina. So if you see the picture over here, so this is a picture of lamina are absent over here. So both neural elements and there is a defect in the neural elements. So this is a case of a spina bifida cystica. And among the spina bifida cystica as well, so it is a meningocele, it is a meningocele and a myelomeningocele. Other can be
अब बजा रही हो घंटी हैं? पहले चीख रही हो कैसे बोलेगी घंटी तो तुमने बजाई है? कहाँ बजाएगी? आज कैसे लेट हो गई? हैं? वही तो मैं पूछ रहा हूँ, मैंने कुछ और थोड़ी पूछा है।
भाई स्पीकर ऑफ हो।
हिमांशु माइक, हिमांशु घंटी भी बज रही है। आंटी तुम पहले आवाज लगाई तो जैसी आवाज लगाई मैं बाहर आ गया, तभी तो मैं कह रहा था मैंने घंटी तो बजा लो। हाँ हिमांशु माइक। दूसरी बार मैं आ गई जब तुमने बजाई, तो बाद में जब बजाई तो आ गई। लाओ तवा दे दो दोगे क्या हाँ चलो तवा धो दियो पहले हैं मैंने कर लिया आंटी तुम्हारी चाय और मैं ब्रेड शेक दूंगा ना हाँ तो धो लो पहले
Who's it? You? I hear you. Awesome.
So this is a picture of a meningocele, and this is a picture of a myelomeningocele, where the neural elements are also beneath the skin. And this is a picture of open myelomeningocele, in which the primitive neural elements forms the roof. So coming to the spina bifida occulta, is seen in 50% of the normal cases. So it usually goes undetected. Small defect in the lumbosacral over the midline, over the lamina. The spinal cord and the meninges are in the normal cavity, or they are in this neural cavity, and thus it goes unnoticed. So sometimes one can find it on the incidental finding on over the X-ray. So usually present over the L5 region of a vertebra. So it presents with a cutaneous lesion. It can be nevus, it can be hemangioma, it can be a tuft of ear, it can be a sacral pit or a lipoma. So if you see this X-ray over here, so over this part, there is a neural defect. There is a defect over the lamina. So this causes the spina bifida occulta. So it's the mildest form. This is a midline defect between lamina and nothing more. Usually L5 level and often encountered accidentally. Occasionally, several vertebrae are involved, and dimpling, tuft of ear, pigmentation, if present, signifies something serious. There can be intraspinal abnormality like tethering of the conus medullaris, or the splitting of the pore, which is also called as diastematomyia. So come to the investigation part of the spina bifida occulta. So one can send for X-rays, we can send for myelogram, CT scan, or magnetic resonance imaging, or MRI. So spina bifida occulta has usually no neurological abnormalities. The myelogram showing no obstructive pathologies. There is non-progressive neurological deficit. If all of these three features are met, no neurological abnormality, myelogram is clear, and there is no progressive neurological deficit, one can just go for non-operative form of treatment, or no active form of treatment is required. But whenever the neurological deficit is present and the progressive myelogram, there is a progressive neurological, and this progressive neurological deficit, and the myelogram is abnormal, so some form of surgical intervention is required. So coming to the spina bifida cystica, is a severe form. The contents of the canal, or the neural canal, or the vertebral canal prolapse through the defect. So in this case, spina bifida cystica, the lamina are completely absent. So these are various forms, three forms usually: meningocele, meningomyelocele, and open meningomyelocele. So it's a 5% of this constitute of 5% total of the spina bifida. Dura mater is open posteriorly, but meninges are intact, and the cord and root remains inside the canal. So coming to the myelomeningocele, this is the most common type. The part of a cord and knob root prolapse into the meningeal sac, and in a more primitive form, the unfolded neural tube element is open out to the environment, and there is no sac covering it. So it's called open myelomeningocele. So come to the previous picture, you can have a clear picture of what these four forms are. So the lamina, there is a defect in the lamina over this part. There is a defect in the lamina, but the neural elements are just over here. Coming to the meningocele, what happens is the neural elements are present, but what happens is that there is a cystic cavity or cystic form. The cyst is formed, which constitutes cystic sac is formed, which constitutes the CSF, and which protrudes out up to the level of the skin. The next form is a myelomeningocele, or the closed. We can say also say it's a closed myelomeningocele. So what happens is all the neural elements are transferred from this cavity or the neural canal, or you can say a vertebral canal, up just beneath the skin, along with the CSF. And the fourth one is the open myelomeningocele. What happens in this is, so this is a new completely developed neural elements. So if these neural elements are not developed properly, so what? So just remains is a, in the primitive form. It just remains is an unfolded part, and and just there is no covering of the skin over here, and it gets exposed to the environment. So this of the open myelomeningocele is the most severe form one can encounter in a case of a spinal bug. So in a case of a myelomeningocele, either it be a closed myelomeningocele, open myelomeningocele, or one, there's a high chances, there's almost surety that the child can have some degree of a neurological deficit. So there is usually the sacral lesion of the lesion over the lumbar spine. The deformities often encountered in our orthopedic practice or day practice are equinovarus or the calcaneovalgus deformity over the foot. There's recurvatum of the knee. There is a hip dislocation, and it's the lower motor neuron palsy we usually encounter rather than upper motor neuron palsy. There's a loss of sensation below the affected level, and there is a loss of sphincter control, or the bowel or bladder habit are lost. And the hydrocephalus may be present in older children. Tethered cord syndrome, which involves the clawing of fluids, a change in the gait, and the incontinence, or the bowel and bladder incontinence are encountered. So if we encounter a case of a child with a spina bifida, we can send them for the screening and some form of investigations. So we can, there is a chance that after the investigations are sent, we'll see the elevated serum alpha fetoprotein level, elevated amniotic alpha fetoprotein, and these are usually done in the second trimester. So if you do a midterm ultrasonography of a pediatric woman, of pregnant woman, so you can detect a 95% case of a spina bifida. So the two signs usually that can be asked in your MCQ. So one is a lemon sign and other is a banana sign. So these signs are intracranial findings which are associated with the neural tube defense. So other investigations you can see for are the plain X-rays, MRI, and the gadolinium enhanced or some contrast enhanced MRI. So it's often believed that the preconceptional 400 microgram of folic acid taken up to 12 weeks of a pregnancy or gestation reduces the incidence of a spina bifida. So coming to the treatment, in recent years, the intrauterine surgeries are developing. So this is very new to us. The intrauterine surgeries are developing that the laminas are closed. Or some form of a closure of a lamina is not intrauterine phase of a child. But care, if the child is delivered, so one must make sure the care of a wound, the dressing over the wound and prevent the infection in a case of open myelomeningocele. The formal neurosurgical closure can be done within the 48 hours of a period, and all the neural tissues should be preserved and covered with the dura. Some centers avoid urgent operations if neurological level is above L1, if there is a hydrocephalus or if there is some severe form of spinal deformities. So not much required at your level, but few MCQs can be asked from this chart as well. So if you get a case of a spina bifida, the timing of treatment is very essential. So early management is of the priority. So what we can do is we can close the skin defect. So if there is a skin defect, we can go for a closure of a skin defect on the day one. So over the first week, we can make a ventriculoperitoneal or SONT, or the BP SONT we call it. And the third one is the stretch and strap for the prevention of deformities. 6 months to 3 years, one can go for orthopedic operations, and there is a high chances that the child with the spina bifida have the urogenital issues or urogenital problems. So after about 6 years or whenever needed, the urogenital operations can be conducted. So spina bifida occulta usually goes unnoticed. It's an accidental finding or incidental finding we encounter whenever we send a patient for an X-ray. Doctor here can be present. Not much of a complication, not much of orthopedic management is required in a case of a spina bifida occulta. But in a case of a spina bifida cystica, what happens is orthopedic management is required, and there's a principles of orthopedic management. All of the principles are focused on optimizing the locomotor function. So the principles of orthopedic management can be the correction of a limb deformities, restoration of a muscle power, and the bracing of the paralyzed limb. So starting with the correction of a limb deformities, it is done to facilitate the bracing of the limb. The next part is the restoration of a muscle power. So there is a neurological deficit. The muscles are weak, so it prevents the recurrence of the deformity. If you restore the muscle power, if you enhance the muscle power, it prevents the further recurrence of deformity. The third one is the bracing of the paralyzed limb. It facilitates walking. So, spina bifida cystica has orthopedic management principles, starting with the correction of limb deformities. Recurrence rate of deformities is as high as muscle imbalance is not corrected. So, the single principle is not acted. All of these are acted on a simultaneously at the same time. So, if you just correct the deformities without correction of a muscle power or either the imbalance power between the muscles are not addressed within a time frame, so there is a high chance that the recurrence can do occur. So the procedures like manipulation and cast application are avoided. So is avoided since there is a loss of sensation and the child can have a ulceration. So the surgery is preferred usually. So we can do a tendon lengthening procedures or some bony procedures or some excision of bone. So other one is the restoration of a muscle power. The restoration of muscle power, if one of the muscle is strong enough and other is weak, the stronger muscles can be weakened by either by a form of a tendon lengthening or some form of tenotomy. But and if the muscles is weak, we can enhance its power by tendon transfer. And afterwards, the restoration of a muscle power, bracing with some form of arthrosis is very much important. So it prevents the deformity and should be applied following a surgery. The other principles of orthopedic management in spina bifida cystica are the prevention of the neuropathic ulcers. The child have no sensations over the some form of some. Suppose if there is a problem at over L2 or L3, the child is significantly below that level, the child won't have any of a sensation. So the care of anesthetized feet, the care of and the use of a soft line footwear. The footwear shouldn't be hard; they may cause ulceration over the part, and the correction of limb deformities should be done. So usually, if there is a plant defects foot, we keep the foot in a much neutral position, in a planted position. The surface area of contact is increased and it minimizes the risk of ulceration. Associated problems like has to be evaluated by neurosurgeons, urologists, the status of a hydrocephalus and kidneys. These are two other structures that are often encountered in a case of spina bifida cystica. Every visit to the hospital requires review by the implant team, even including physiotherapists. So in the team, there should be a neurosurgeon, there should be an orthopedic surgeon, there should be a urologist, there should be a pediatrician, and, and eventually there should be a physiotherapist for the rehabilitation. Last So the final topic for today's class is osteogenesis imperfecta. So osteogenesis imperfecta, also known as a brittle bone disease, so it's a synonym for this uh, problem or synonyms of this disease. It can be asked in MCQ for you. It's a rare genetic disorder in which the bone are fragile and fracture occurs easily, resulting in the bone deformity. So it's usually an autosomal dominant disease. A person with a OA has 50% chance of passing it into the gene and the disease to their children. So the main biochemical problem in this osteogenesis imperfecta is it involves the errors in the synthesis of collagen, which is a connective tissue problem. So the science have given or the classified osteogenesis imperfecta into four systems. So it has four types based on the inheritance, it's autosomal dominant or autosomal recessive variety, and with the clinical findings of each of the type. So type 1 and 4 are mild manifestations of disease and can persist up to the adulthood. But type 2 and 3 are more severe form and can result in the fracture in utero or during birth process or in the early child. And are usually associated with the high mortality rate of the affected child. So this is a silence classification we are talking about. So type 1 is a mild forms. So inheritance can be autosomal dominant or some form of new mutations. The features usually are the child will have a blue sclera, so they will have a mild bone the fractures after walking or the minimal deformity can represent. The type 2 is usually known as a lethal variety or lethal variant. So there can be a blue sclera. The child can have a blue sclera, multiple intrauterine fractures or severe deformity, stillbirth or neonatal death can happen. The inheritance usually is the autosomal recessive form. The more the severity of the form of osteogenesis imperfecta, the inheritance changes itself into the autosomal dominant into autosomal recessive variety. So the type 3 or also known as a severe deforming form can have the child can have a normal sclera. So there can be the indigenous imperfecta, the usually associated with the severe deforming. So there can be frequent fractures, there can be deformity of long bones, the child can have a short stature, and there can be associated scoliosis. So the way the inheritance is autosomal recessive. The fourth type is intermediate type. The child will have a normal sclera. There will be moderate bone fragility, moderate deformity, short stature, and the possible indigenous imperfecta can be present. Associated with that, the inheritance is usually autosomal dominant or some form of new mutations can happen. So coming to type 1 osteogenesis imperfecta is the most common variety. People will have type 1 disease generally reach normal height, and there are few obvious skeletal deformities are present. Typically causing more fracture during childhood than in adult. Hearing loss is pronounced and usually begins in early childhood. So type 2 osteogenesis imperfecta is the most rare and the most severe form. It produces numerous deformities of the skeleton. Usually happens in a intrauterine period, and the child that is born is stillbirth. There is a high chances that the born child is stillbirth. So there is abnormal collagen formation profoundly affecting the lungs, causing significant breathing problems. Even if the child is born, it's very less likely the child will survive. Coming to type 4 osteogenesis imperfecta is a more severe than type 1, but less severe than type 3. The type 3 is a severely deforming osteogenesis imperfecta, which has the autosomal recessive pattern of inheritance. In the case of a type 4 osteogenesis imperfecta, the fractures are most common before the puberty, and they are gradually the incidence of a fracture declines. The hearing loss begins early in the childhood, is similar to the type 1 osteogenesis imperfecta. In type 4 osteogenesis imperfecta, hearing loss begins in early childhood and is often. Come to type 3 osteogenesis imperfecta. So it produces the severe, obvious skeletal deformities. The fractures before birth are common. So the child with the fractures, if you encounter the multiple numerous fracture, either over the clavicle or the upper limb or lower limb, so you can suspect osteogenesis imperfecta in a child. If a child is born with the fractures, unless it's some idiopathic or some iatrogenic cause. So ultrasonography can detect them in the fetus. So it also affects the lung and the muscles. The hearing loss begins in early childhood and often becomes complete by adolescence. So usually the hearing loss is of a sensory neural variant. The signs and symptoms usually are all people, all children with osteogenesis imperfecta have weak bones, which make them susceptible to the fractures. The persons with osteogenesis imperfecta are usually below average height, Scottish stature. However, the severity of disease varies greatly. Individual to individual, the severity of disease may vary. The classical symptoms include the osteoporotic bone, history of multiple fractures, the bony deformity, the poor skeletal development, soft brownish teeth, hearing loss, blue tint to the whites of their eyes or blue sclera. So because of type 1 collagen is also found in the ligaments, the persons with osteogenesis imperfecta has loose joints, or there can be the hypermobility of the joints, and there can be a flat feet. So other symptoms of more severe form of osteogenesis imperfecta can include the bowed legs and arms, kyphosis, scoliosis, or S-curved spine. So this is an example of a child with this osteogenesis imperfecta. There is a bony deformity or multiple bone deformity. You have the right shoulder, right upper limb. You can see it. There's a deformity over the spine as well. There's a deformity over this part of the hip as well, and there's deformity over the foot or both of the foot. So coming to the sclera part, usually they have a blue sclera. There's a blue tint over the sclera. The other is a soft brownish teeth. Or you can see the dent is in a imperfecta. The development of the tooth is affected, and usually you can see this part of the tooth malformations. So if you do the X-ray of a child, you can identify or you can significantly say there's some sort of a bony deformity. So the intermediate canal is poorly developed, and the child will have a history of a significant previous fractures which heal by themselves. And they will have some sort of a bowing over either of upper limb or either of a lower limb. So this is a case, or this is a pediatric case, or neonatal case. I suppose that this baby extremities are positions early. So the child, so this is a form of a type 3 osteogenesis imperfecta, you can say. So what happened was the child was born with multiple fractures due to osteogenesis imperfecta. So this disease leads to the multiple fractures. So basic problem in this disease have been the formation of type 1 collagen that forms the bony matrix. So there are several other parts. So if you see over here, the child have a fracture over his right lower limb. So he can have fracture over the body as well. So how you diagnose is you can send for the blood investigations, you can send for serum alkaline phosphatase. So you found it's generally increased. So once you diagnose, once after the clinical suspicion and the confirmatory diagnosis from the blood investigations, so you can send for or you can after the X-ray, you can go for the treatment purpose. For treating the case of osteogenesis imperfecta, the, the fractures are treated generally conservative. So targeting a balance between the immobilizing a fracture long enough for it to heal and allowing normal muscles function as quickly as possible. So that's how you treat a case, generally case of osteogenesis imperfecta. Physical activity usually helps strengthening the muscle as well as the bone, which in turn minimizes the fracture. So you have to give the range of motion, you have to rehabilitate. The purpose of rehabilitation is very much essential in the case of a pediatric part of orthopedics. So either it be a poliomyelitis, either it be a spina bifida, or it be a case of osteogenesis imperfecta. The most numerous fractures occurring during the childhood when the bones are growing and thus have a lower mineral content. The pediatric bones have a lower mineral content and they are growing in size. So they are more vulnerable or more susceptible for the fractures to occur. The risk for a fracture is lifelong. However, if in a case of a type 1 and type 4 osteogenesis imperfecta, the child will survive for a longer period of time or he will live up to the adulthood as well. So there is a high chance that there is a risk of a fracture throughout his life. So, however, and may increase in the woman after menopause. The bone, or if a patient is of a female, so the intensity of a fracture even may increase further even after the menopause, where the bone density will gradually decline. So there is no strict form of treatment. So it's just a manipulated form. It's just a modulated form of treatment. So supportive form of treatment. All of these provide provides the palliative form of treatment. So if there is a fracture, for the palliative purpose of fracture, either do a splintage or bracing, some sort of bracing. So one can start with the steroids. You can give calcium, you can give vitamin C, you can give sodium fluoride. So physiotherapy is an essential part, like I've already discussed. You can do for casting or bracing, in orthopedic point of view. And the other thing is the telescopic intramedullary. So if you suspect osteogenesis imperfecta in a child, even if it doesn't have a fracture, if he have some sort of a, you say a single cortical fracture, some brain stem fractures, what we do is we usually put a telescopic intramedullary dots. So what they do is they maintain the mobility and promote the ambulation. Once you, as early as you start the mobility and you start to ambulate the child, so you will have more stronger the muscles and eventually leads into the increased bone strength as well. So there is a recent theory over the bisphosphonates used. Bisphosphonates are also used nowadays, but the its purpose has not been yet to be established. So even if you treat osteogenesis imperfecta in a lot of ways, either by giving drugs or some sort of a operative treatment or telescopic inflammatory rod. So you have to, the first thing you have to explain to the child, explain to the parents before starting a form of a treatment is you explain the prognosis to them very beautifully. You don't create a much of a expectations for them. So how much we have to expect, or how much a child can have, or what form of prognosis can a child have if he or she had a so it depends on the variety of osteogenesis imperfecta. Type 1 or the mild osteogenesis imperfecta is the most common form. So you have to explain that way. The person's this can have a normal lifespan associated with some sort of other complications like this. Uh, Fractures in the tribal fractures can happen. There can be heterogeneous imperfecta. There can be sensory neural hearing loss. The type 2 is a severe form. If you see that, so even if so if you get a case of a type 2 osteogenesis imperfecta, so what you see is a severe form of osteogenesis imperfecta.